Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Let's get into a few additional points that are worth discussing in terms of collimators. Remember that collimators have a lot to do with the resolution of an imaging study. One of the main ways you get positional data on an image in general nuclear medicine imaging with a gamma camera is through collimators, in that a collimator only accepts counts from a small region of the object that is directly in front of the collimator. So you know if you are getting counts from a certain collimator area on an image, that corresponds with the position of where the radiation is located in the body part being imaged. The smaller the collimator holes, the higher the resolution, but also the lower sensitivity, because you will capture fewer counts in a given amount of time. For illustration, and I would not worry about memorizing these numbers, but it's just to help you understand, a low-energy all-purpose collimator accepts about 500,000 counts per minute, whereas a low-energy high-resolution collimator accepts only 175,000 counts per minute. So there is quite a difference here in terms of the sensitivity of imaging between a LEAP and a LAIR collimator. And there is also a difference in the speed of which you can acquire an image with the same amount of counts, because low-energy all-purpose acquires 500,000 counts per minute, and a low-energy high-resolution only accepts 175,000 counts per minute. But on the other hand, a low-energy high-resolution collimator gives you better resolution because you are much more selective about what counts you will accept. So those 175,000 counts that a low-energy high-resolution collimator does accept are more likely to be true events and less likely to be scatter. Therefore, you get better resolution with a low-energy high-resolution collimator. In terms of resolution numbers, a low-energy all-purpose collimator has resolution of roughly 10 millimeters at 10 centimeters from the collimator, whereas a low-energy high-resolution collimator has a resolution of about 6 millimeters. So you get an improvement from 10 millimeters to 6 millimeters when you use a low-energy high-resolution collimator. What about iodine-123? What collimator do you use for that? First, think about what energy you're dealing with iodine-123, and that is 159 keV, so that is slightly above technetium. The question is, do you use a low or a medium energy collimator? I don't think they will really ask you this on the ABR core exam, but I'm discussing it just in case. And the reason I think it may not be asked is you might see some variations. Some sites can get away with using a low energy collimator, others may use a medium. But basically, multiple studies have shown that a medium energy collimator is better with iodine-123, so if they happen to ask that, I would select medium energy collimator. In general, if the majority of the energy is 140 keV or lower, I would choose a low energy collimator, and if it's above 140 keV for the majority of the energy, I would choose either a medium or high energy. Anytime they give you I-131, choose high energy, and anytime they give you anything other than technetium or thallium, choose medium energy. What collimator would you use for the weekly bar phantom spatial resolution quality control test? Well, for this test, you want to assess the resolution of a system, so I would go with a low-energy, high-resolution collimator, and that is the answer. For your spatial resolution quality control test, where you use the bar phantom on a weekly basis, you use a low-energy, high-resolution collimator. I would know that collimator septae are made of either lead or tungsten. Tungsten is more dense, so it allows you to have smaller thickness of the septa to get the same blocking ability of the gamma rays that are scattered. And you need to know in general that you use lead or tungsten because these are really dense metals, so the septae can be made as thin as possible. Because the thicker the septal width, the less area you have on the image to accept counts, and the lower sensitivity of your imaging. So you really want dense but thin material to make your septae to maximize your image performance. I would know that on a nuke's quality control testing procedure, if they throw out an extrinsic test, such as a test for extrinsic resolution or an extrinsic flood, that means that you have the collimator in place. I remember this by remembering that an extrinsic test has the radioactive source external to the collimator, whereas an intrinsic test is done without a collimator in place, so it tests the intrinsic performance of a gamma camera. I don't know if that's helpful for you, but it's helped me remember this for years. So remember, extrinsic is done external to a collimator, which means you have the collimator in place on the crystal surface and then the radioactive source on the outside of the collimator. So finally, let's talk about how we get rid of scatter in nuclear medicine. And there are a few methods I would be aware of, and the first obviously is collimators. However, the primary purpose of a collimator is to provide positional information on where a count comes from in the body, because the holes in the collimator will only accept counts from objects that are directly in front of them, and counts that come in from objects that are not directly in front will be off-axis and therefore not accepted. I would remember that increasing the effectiveness by which the collimator blocks scattered radiation results in lower sensitivity but better resolution. I would know that 2D PET imaging does use collimators, and now that's getting kind of old school to have 2D PET, but it still may show up on a board exam. So know that 2D PET uses collimators, and those collimators have to be tungsten, not lead, because you need that increased stopping power. But 3D PET does not have collimators. All current PET systems really are 3D PET, but that still can show up. So 2D PET has collimators, 3D PET does not have collimators. Hence, 3D PET is more sensitive, and these 3D PET systems use other methods to block scatter so that you still maintain resolution while also increasing sensitivity by not having a collimator in place. Pulse height analyzers also help you get rid of scattered radiation on your image. This happens because on a pulse height analyzer, you are able to tell an image that you only want it to select certain energy ranges. So if a count comes in that is outside of that energy range window, it rejects it from the image. And the majority of counts that come in outside of the expected energy range window do so because they have been scattered through Compton scatter effects. So selecting a narrow energy range on the pulse height analyzer will make it so the system only uses gamma rays with the desired energy for an image, and scattered gamma rays that have given off portions of their energy from the Compton scatter event will not be accepted in the final image. You need to know that if you select the wrong energy, you will get a low-resolution image with poor anatomic localization, and this is called off-peak imaging. So for example, if a technologist forgets to switch from a peak of 140 keV used for technetium when imaging with something that has a different energy like gallium, you will get off-peak imaging because the system will be expecting to see a lot of those 140 keV gamma rays, but now you're imaging with gallium, and so most of the useful radiation will be blocked by the system, and it will only be accepting 140 keV, which in the case of gallium imaging would be mostly scattered radiation. So not surprising that you don't get a great image. Another common mistake would be to forget on the first patient of the day to switch from the energy for cobalt-57, which is 122 keV, when imaging with another radiopharmaceutical like technetium. So the technologist comes in, does the cobalt flood for QC testing, and appropriately sets the pulse height analyzer peak at 122, and then the first patient comes in, say they're using tech, and forgets to change it to 140 keV. So suddenly the system is only accepting 122 keV energies, and you've blocked the majority of the 140 keV that is useful, and you are now imaging mostly scatter. So your image looks off-peak, which makes it look really low resolution. Finally, let's talk quickly about time-of-flight PET and coincidence detection on PET scanners, and I will cover this in more detail on a future discussion on PET physics and PET imaging. But quickly now, when you use a PET detector ring, these have such high temporal resolution that the ring can detect within nanoseconds if a photon pair strikes one detector slightly before the other 180-degree opposed detector. So remember, with PET imaging, you're detecting annihilation photon pairs that come off at about 180 degrees from one another. And the PET system counts an event as a true event if two detectors 180 degrees opposed are activated at roughly the same time. If the event happens in the body closer to one of these detectors than the other, that ray will actually hit nanoseconds earlier on the closer detector than the one that's further away. And the systems now have such good temporal resolution that it can detect, hey, this detector went off just the tiniest bit before the other detector 180 degrees away. Therefore, the event must have been slightly closer to the detector where the event was imaged earlier. And what this does is allows the system to use the difference in photon pairs hitting the detectors in time to figure out that the event must have occurred closer to one detector than the other. And by using that method, you are able to reduce the length of the line of response and thereby get rid of scattered radiation and improve the resolution of the image. And in general, coincidence detection in PET, where you only accept counts when two detectors 180 degrees opposed are activated at nearly the same time, also allows you to get rid of scattered radiation, because scattered events won't have that same coincidence detection. Remember that PET systems only accept counts that are registered at the same time on detectors that are 180 degrees opposed. And by using time of flight PET, you can further guess in the body that the event may have occurred closer to one detector than the other. One final reminder is that with low energy collimators, these are predominantly for technetium and thallium imaging. Medium energy collimators are predominantly for gallium-67, indium-111, and iodine-123 imaging, and high energy collimators are mostly for I-131 imaging. Thank you so much for listening. Keep up the good work with studying. I know it has to be pretty hard to keep focused during this time where the core exam has been delayed several months and there's so much disruption in your life in terms of normalcy with the COVID pandemic in May of 2020. I just want to congratulate you for listening to this podcast and keeping your education and learning going despite challenges. Again, you have to study really hard to pass these examinations. You can do it. You're going to succeed. I hope that was helpful. I have a study guide available for free download on my website, www.theradiologyreview.com, so make sure and go and download that to help drive home some of these concepts, and I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.